And I've been working in the quality department, abstracting the core measures since 2009. And we decided in quality that we needed to improve our stroke program. We identified some issues that we weren't up to snuff. So in 2010, we partnered with Virginia Mason, and we started voluntarily abstracting in Get With the Guidelines. The core measures with CMS were limited, and with our voluntary data abstraction, it just wasn't giving us the data to help us do improvement plans. So with Virginia Mason's help, we were able to data abstract and improve our policies and procedures. Our data was so good. Within 2.5 years, we won the Silver Award in 2013 in Get With the Guidelines. It showed and produced a lot of improvement events. With core measures, I've always thought that I was the girl that walked around and told everybody what we were failing on. What I've decided to do is let everybody know that failures are not failures, they're just opportunities for improvement. So with that, I want to just give some brief data. And I have all the Get With the Guidelines dashboards up on the wall, and I'm going to go through those quickly. Let's see. So that tells us that with our stroke award, we had to get 85% on all the data elements with Get With the Guidelines, which is quite an astronomical event in every single data element. So to be able to meet the data elements for Get With the Guidelines, we have to have at least 75% or greater in all the data elements. I want to actually start with down below with the inpatient data. It starts with the stroke TIA, discharge education. This one right here. We're 78.9%. We're continuing to do discovery data on that. We've had 4 failures in the last 2 years, but it's been a quality improvement project to make sure that our nurses are educated with the stroke education. And to take a cliche from Virginia Mason, a TIA is just a stroke that didn't stick. And the education with discharge education on the clinical care station tab for stroke is to make sure that all of that education is presented to the patient before they're discharged, whether they have a TIA or an actual diagnosis of a stroke. So that's what we're trying to make sure that is a message today for that. The rehab assessment on the inpatient side, we're at 94.4%. That's topped out to be quite an improvement project with the rehab department. And they were getting orders through a printer machine, and especially on the weekends, and they were not going to allow a printer to affect their failure rates. They made process improvements on communication through the huddle, and making sure that they're communicating with the hospitalists to be sure that they're using the stroke order sets so that they get the PTOTST rehab orders, and that things are initiated as soon as possible. So as you can see, rehab needs kudos for that. And that A3 was developed. That's an error. That should be 2013, with that process improvement. So really proud of that. The LDL monitoring, we're 95.2%, and that's with the CPOE order sets to make sure that the hospitalists are identifying those strokes right at the get-go, that they're using the stroke order sets, and they're ordering the labs appropriately, and that they're getting done. And if the LDL is above 100, that the statins are considered and ordered if they're appropriate. The other issues that I don't have on the board, but I do have up here on our boards, are VTE. We're the best with CMS also. We're 92.3%. AFib, anticoagulation, is 100%. Smoking is 100%, and that's kind of hardwired into clinical care station. And the achievement benchmark for the gold standard for Get With The Guidelines is 85% above all of the data metrics. And that's our hope and our goal. So how are we going to meet that? Whoops.
Yeah, it kind of had a little mind of itself. So
It did.
Just keep clicking forward, you'll get there.
So this next slide is going to, that was our inpatient side. The situations for our opportunities for improvement are on the emergency room side. In 2013, for our stroke designation, Linda worked real hard to make sure that we were all certified in the NIH stroke scale, and to make sure that we did that and initiated it as soon as possible in the emergency room. For our 2014 data, these are the metrics for need improvement. We were 70.7%, so we're going to revisit that and make sure that we get everybody certified, and that's the primary focus of the stroke alert code. The dysphagia, we're at 81.2%. We did an A3 when we started seeing that we were falling down below our goal of the 85%. We did a A3 on that, focusing on that swallow screen that Linda and Jeff focused on earlier in their presentation. The TPA inclusion-exclusion, we're at 71.4%. Again, we did a A3 improvement on that to make sure that our paper inclusion-exclusion form was being done and made out and appropriately initiated in our stroke kit, and reinforcing that with education with the providers. And then the making sure that the last time known well is identified so that the assessments can be made as soon as possible, because our door to needle time to helping the pharmacist decide whether they need to start getting the 2PA ready, because our goal is within 60 minutes. So the 60% is something that has prevented us from getting our award this year, and that's something that we are working on, and we'll probably revisit that A3 because our numbers have not improved that dramatically. And then again, the discovery data with the discharge stroke scale is something that we're really working hard on too, and it's improving dramatically. So what I want to say is thank goodness for Virginia Mason. This telestroke program, I think, is going to help us accomplish our goals. And thank you very much. I would like to point out that on our graphics from Get With The Guidelines, the aggregate data is also comparing other critical access hospitals, and we meet and exceed all the other critical access hospitals with Get With The Guidelines, but that's why we're the top 20.